Hi, everybody. This is Adam, and I've got another talk for you on respiratory distress. By the end of this module, I think you should be able to explain the physiology of respiratory distress, and you should be able to use that knowledge to develop a differential diagnosis that includes the most common disease processes. You should also be able to assess a patient in respiratory distress by considering oxygenation, ventilation, and worker breathing. The Nightmares program gives us the respiratory assessment triangle with 3 different things that you need to assess if you've got somebody who's having trouble with their breathing. You need to look at O2, CO2, and effort. O2 refers to oxygenation, which is the process by which you bring oxygen out to tissues. CO2 refers to ventilation, which is the process by which you excrete carbon dioxide. And effort refers to their work of breathing, because muscles are required for both oxygenation and ventilation to work. All 3 of those areas need to be assessed and stabilized if you have someone in respiratory distress. Let's look at oxygenation a little bit more closely. And when you think about this process, I would encourage you to think anatomically. So just imagine the flow of oxygen moving through your body. You start with oxygen in the air, and that oxygen has to move through your lungs. It has to make it all the way down to your alveoli so it can diffuse across the alveolar membrane. And there has to be some blood flow in the lungs so that it can get picked up by the blood vessels. The blood vessels contain hemoglobin, and hemoglobin carries the oxygen all the way out to tissues. Out of all these processes, oxygen in the air probably deserves some special mention, partly because it's almost never the problem you're going to deal with, but it is almost always the first solution that you're going to reach for. You can always increase the amount of oxygen that's in the air by putting on an oxygen mask or by using nasal cannula or by using any number of different devices. So you have to keep this in your back pocket. When you think of ventilation, you kind of follow the path of carbon dioxide just in reverse. So carbon dioxide first gets produced by tissues, it circulates through to the lungs, has to make it to the alveoli and cross the alveolar membrane, has to move through the lungs, and then eventually just gets excreted into the air. And out of all of those processes, moving through the lungs probably deserves special mention. There's a couple of things here that will cause problems with ventilation and accumulation of carbon dioxide, but the solution almost always comes down to moving more air. It's, can you breathe faster? Can you take deeper breaths? When we're looking at problems with oxygenation and ventilation, there are 2 more things that I want you to keep in mind. So one is that all of this requires respiratory effort. You need to move muscles to move air. And if you're not moving muscles, you can't be oxygenated or ventilated. The second thing, and I think this goes without saying, but all of this requires an open airway. So if there is a barrier between your lungs and the outside world, oxygen is not going to be able to find its way in, and carbon dioxide is not going to be able to find its way out. Today's talk is not really on airway stuff. We're going to do that in a later module, but I need you to remember that this requires an open airway. So if you follow the path of oxygen and carbon dioxide through your body, you'll find there are 5 areas where things can go wrong. You could have low FiO2, hypoventilation, a diffusion impairment, a VQ mismatch, or low oxygen content in your blood. FiO2 is just short for fraction of inspired oxygen. So this is just a fancy ICU term for the percentage of oxygen that's in the air around you. So room air would have an FiO2 of 21%. And if I put an oxygen mask on you, I can make the FiO2 go up to 50% or 90% or 100% or really whatever I want. VQ mismatch is another term that I think confuses people sometimes. Just know that the V stands for ventilation and the Q stands for perfusion. So in my example, this is VQ mismatch because the blood flow is not getting to the lung. So you've got a low Q and ventilation is preserved. So you've got a normal or a high V. Strictly speaking, hypoventilation and diffusion impairment are also forms of VQ mismatch. They're just kind of the opposite version of it, where you've got reduced ventilation and you've got preserved or normal perfusion. So technically speaking, the VQ mismatch that I describe would be like a high ratio VQ mismatch, and hypoventilation and diffusion impairment would be a low VQ mismatch. I don't think you really need to know those details, but if you're reading, you'll hear things tossed around. I think it's easier to think of hypoventilation, diffusion impairment, and VQ mismatch as separate processes to keep it straight in your head. If you can keep track of these 5 processes, you can use them to build your differential diagnosis. So for example, if we look at low FiO2, that would refer to environmental problems. So maybe a scenario where the patient is locked in an enclosed room and the available oxygen has been depleted. Usually a problem that's going to be solved by the time you get involved. It might also refer to altitude issues. So if you're doing expedition medicine and you're climbing a mountain and you go up and up and up, then the level of oxygen in the environment is going to go down and down and down. When we talk about hypoventilation, we're getting into problems that you're more likely to see in the hospital. So hypoventilation would be a problem with COPD or asthma because air is not moving through. It would be a problem with a pneumothorax or a hemothorax where the lung is collapsed and so air is not moving. And it would also be a problem with apnea or somebody who's sedate or they're just not making good enough respiratory effort. Now, a couple of pro tips here. COPD and asthma, those are associated with wheezes. Pneumothorax and hemothorax, those are associated with decreased air entry on one side. And poor effort is usually clinically obvious. Just look at the person and talk to them. And can they speak back to you, or are they obviously breathing or obviously not breathing? Usually you can figure these things out by just looking at the person and using your stethoscope. Diffusion impairment refers to diseases of the alveoli. So you'll see that with pneumonia, where the lung is full of gunk, pulmonary edema, where the lung is full of fluid, or interstitial diseases where the alveolar membrane is all thickened and scarred and gas exchange just isn't happening because it's damaged. These are other issues that you can often figure out with pretty easy bedside tools. So all of these processes are ones that create crackles. They all show up to some extent on chest x-ray, and they all produce B lines with your bedside ultrasound. So sometimes you can figure this out right on the spot. VQ mismatch refers to problems with blood flow. So that would be an issue like a pulmonary embolism, where there's a big blood clot in the lungs vasculature, and you can't get blood flow because the blood just can't get around the clot. Or it could refer to a cardiac problem like right to left shunt, where you've got like a congenital defect, like a VSD or an ASD, and blood is going right from the right ventricle straight to the left side of the heart and just bypassing the lungs completely. Diagnosing this starts getting tough, and everybody struggles with this. A pulmonary embolism, you probably need something like a CT scan, and that's going to be tough to get if the patient's in real respiratory distress. Right to left shunt is something that probably requires an echo to diagnose, and that's another thing that's sometimes hard to get quickly and can't really be done in somebody that's really struggling with their breathing. Low oxygen content is the last category, and this refers to problems with the blood. So the most straightforward issue here would be something like anemia, where there's just not enough hemoglobin in the blood to carry high enough levels of oxygen out to tissues. But this also refers to weird and wonderful stuff. So there could be toxins like carbon monoxide or cyanide or methemoglobinemia, where the blood is just poisoned and it's not able to carry oxygen even if there was oxygen there. This could also refer to hemoglobinopathies, so like sickle cell or thalassemia, where there is hemoglobin and there's enough hemoglobin, but the hemoglobin is dysfunctional in some way and it's just not carrying oxygen the way it normally would. This also refers to shock states too. So if you imagine somebody with really low blood pressure or a really weak heart, sometimes blood just isn't circulating enough and it's just not carrying oxygen far enough. Or maybe the tissues are really sick and they're just sucking more oxygen out of the blood than usual. So that could create a problem too. Most of this stuff you could probably figure out with blood work, but with the exception of anemia, sometimes that blood work is hard to get. So a CBC is pretty straightforward, but tests for, carbon monoxide or sickle cell disease, those are often send-outs that take a couple of days to turn around. And shock states, there's no magic way to diagnose this. This is usually something that an ICU doctor figures out a couple days down the road, and they kind of use all of the information and all of the tests that they've gathered so far to figure out that that's the problem creating hypoxia. And that pretty much summarizes the differential diagnosis for respiratory distress. Remember to think anatomically, follow the flow of air from the environment all the way out to tissues, and think about these 5 different categories when you're trying to figure out what's going on with this patient. Let's bring all this back to that respiratory assessment triangle. I told you that there are 3 processes that you need to assess. You need to look at oxygenation, ventilation, and work of breathing. And I told you that all 3 of those areas need to be assessed and stabilized. So how do you assess these things? Oxygenation is our first consideration. And to assess that, you're going to use that SpO2 monitor and put that on their finger. While you're doing that, you should probably also apply some supplemental oxygen. So a nasal cannula or a non-rebreather mask or whatever device is handy. Remember that the SpO2 isn't always a reliable measurement. So you've all seen patients where the waveform is poor because the patient's hands are really cold or they're wearing nail polish or they're moving around or something like that. But hypoxia kills you really quickly. So if their oxygen saturation is down to 70%, you've got minutes to do something before this patient dies. If you're not getting an SpO2 or it comes up and it's low, put oxygen on them, get things moving. So all of your patients really should get supplemental oxygen as soon as you know that they're in respiratory distress. Ventilation is the next thing that we need to assess. How do you do that? Well, most people do it with a blood gas because you can directly measure the amount of CO2 in the blood, and that's probably the most accurate way to do this. But getting a VBG does take time. For the most part, that's probably okay because an accumulation of CO2 usually kills you slowly, but you should be able to figure this out by just looking at the patient. Ask yourself, are they moving air? So get out your stethoscope and listen. Do you hear good air entry or is it reduced? What is their respiratory rate? Are they breathing really fast? Are they breathing really slow? And think about their tidal volume. Are they taking deep breaths? Are they taking shallow breaths? Give yourself some sense of what's going on. Using your stethoscope here is also a good idea because you might pick up some clinical clues that will get you to the diagnosis. So if you hear wheezes, if you hear crackles, if you hear unilateral air entry, you might know what's going on and what's causing this respiratory distress immediately. Effort is the last bit of the triangle that we need to assess. And this is an essential part of the exam because oxygenation and ventilation might be doing okay, but you have to ask yourself, how much work are they doing to maintain those? If their work of breathing is really high, oxygenation and ventilation might not stay very good for very long. How do you do this assessment? For the most part, you just look at the patient and talk to them. When they speak, how many words are they getting out? Are they speaking in full sentences or is it just 1 or 2 words at a time? Are they using accessory muscles? Can you see intercostal muscles or a tracheal tug, or do you see their diaphragm and their belly moving a lot? And what position are they in? Are they lying comfortably on a stretcher or are they sitting bolt upright, leaning on their hands? All of these are signs of respiratory distress that needs to be dealt with. So these 3 things together give you the respiratory assessment triangle. You need to assess oxygenation, ventilation, and their work of breathing. Remember that deterioration in even one of those areas usually means that you need to escalate therapy somehow. How do you do that? Well, that's coming up in our next talk. So I will see you in that one.